Hi everyone, my name is Dr. Munir Jan. I'm an anesthesiologist and critical care specialist. Today I will be discussing about rapid sequence intubation. What is the importance of rapid sequence intubation? Which are the patients where we have to do rapid sequence intubation? And what are the contraindications of rapid sequence intubation? Why pre-oxygenation is important? What is the concept of delayed sequence intubation and modified rapid sequence intubation? So I will be discussing each and everything in this video. So let's begin. Rapid sequence intubation is one of the preferred method of securing airway in critically ill patient or injured patient where there is high risk of aspiration. Now what we do in rapid sequence intubation, we give induction agent quickly followed by neuromuscular blocking agent in order to create optimal intubating condition and decreasing or minimizing both the time of patient apnea and time when the patient's airway is unprotected. Patient during the time of apnea, you don't have to ventilate, but yes, there are conditions where you can go for gentle ventilation when the patient is getting hypoxia during that short period of apnea. So that is what is the concept of modified rapid sequence intubation. Now, what are the contraindications for RSI? So there is as such no absolute contraindication for RSI. The most important contraindication to RSI is anticipated difficult or impossible rescue oxygenation. Now, if you have a patient where you have done the airway assessment and you have anticipated difficult airway, if you have a patient where there is rescue oxygenation is impossible, that makes RSI as a relative contraindication. Now, these are the steps that we have to follow. These are the key steps that we have to follow while proceeding for RSI. Now, the first important thing is the preparation. Then pre-oxygenation, physiological optimization, paralysis with induction, or positioning, placement with proof, and post-intubation. Yeah, now the first is preparation. Now, in the preparation, there is two things that you have to first do. One is the airway assessment to know about the anatomical difficult airway, and second is the overall assessment of the patient to know about the physiological difficult airway. Now, what is physiological difficult airway? If we see the definition, the physiological difficult airway is one in which physiological derangement places the patient at great risk of cardiovascular collapse during the peri-intubation period. Now, these conditions could be hypotension, hypoxia, left ventricular failure, and metabolic acidosis. These all things can make patients high risk for peri-intubation cardiovascular arrest. So if you have done the assessment and you feel that there is high possibility of arrest or there is high possibility of difficult airway, then find out some other alternative like awake intubation. Now this graph, linear graph, is showing us the importance of first pass success. That means how much time, how many attempts you have taken to intubate the patients. If you have taken one attempt, then the possibility of adverse effects as a result of RSI will be less than 20. If you are taking two attempts, it will be 47%. If you are taking three attempts, it will be more than 67% as shown in this graph. Now it means that you have to make sure that you are able to pass endotracheal tube as soon as possible. Now, there is one thing also, there has been studies that video laryngoscopy is better for first pass success than the conventional laryngoscopy. So if you are expert, if you have availability of video laryngoscope, it's always better to go for video laryngoscopy rather than conventional laryngoscope. Now, the other thing is about, because you have to put the tube inside, so you need to get prepared for endotracheal tube intubation. And these are the things that you need, like you have to you should have a working suction apparatus ready, tools for intubation has to be ready, oxygen source for pre-oxygenation and ongoing ventilation, positioning of the patient, monitoring, ECG, pulse oximeter. These are the basic monitors that you have to attach. Assistance, a good assistance is required. And the drugs, intravenous access drugs, you have to already label what are the induction agents or sedatives or muscle relaxants you are going to use. And more important, you have to make sure what is the dose you are going to give at the time of RSI. And there is one thing that you must check before proceeding. It is the good IV access. Now, pre-oxygenation, this is one of the vital important part of rapid sequence intubation. Now, pre-oxygenation, if we say as a layman, you have to oxygenate before you proceed for endotracheal tube intubation. You have to oxygenate the patient before giving any sedatives and muscle relaxants. So you pre-oxygenate, you give oxygen, and that too oxygen has to be 100% ideally. Now, pre-oxygenation, how pre-oxygenation is going to help the patient to increase that safe apnea time. Now, what is safe apnea time? Till you give the muscle relaxant up to the patient had this saturation less than 90%. Now, this is what is the safe apnea time. Muscle relaxant, when the patient gets saturation less than 90%, that is the safe apnea time. So what you are doing with pre-oxygenation, you are increasing the safe apnea time. Now, how it's increasing the safe apnea time, we have to go to the concept of functional residual capacity. Our functional residual capacity is simply when I exhale the air, normally in the quiet breathing, I exhale the amount of air that is inside my lung, that is the functional residual capacity. That is the combination of expiratory reserve volume and the combination of residual volume. And in that percentage, if you see the percentage of oxygen at the normal atmospheric air, you have 20% of oxygen. Now, when you are doing this pre-oxygenation, you are filling that functional residual capacity with oxygen. Now, if you do the intubation without pre-oxygenation, the patient can have this safe apnea time up to 1 minute. So after 60 seconds, and in critically ill patient, it will be more or less. The patient can have desaturation. Now, if you have done this pre-oxygenation, it will increase this safe apnea time because it has filled this whole of the functional residual capacity is filled with oxygen. Nitrogen is out. Also, that is the reason this is also known as the denitrogenation. So you have whole lung functional residual capacity filled with oxygen that can be utilized during that apnea period, and patient can have increased safe apnea time. There has been this study. This study was done in patients undergoing for operation general anesthesia. Okay. So they were not critically ill patients. They were not ER patients. Now they have seen that if you do the pre-oxygenation in such patients, in normal adults, you can see the saturation time or safe apnea time is up to 8 minutes. For pediatric patients and patients who are obese, pregnant patients, the safe apnea time will vary up to, what you can say, safe apnea time will vary up to 3 to 4 minutes. For critically ill patients, it will be more or less. But overall, if you have to say about pre-oxygenation, it is definitely going to increase the safe apnea time irrespective of what is the patient. Now, if you don't do the pre-oxygenation, you have only 60 seconds for normal adults, or you can have less than 60 in a patient who is already critically ill. So advice is that you have to do pre-oxygenation. Don't take it lightly or don't underestimate this pre-oxygenation. You have to pre-oxygenate. Now, there are multiple ways how you can pre-oxygenate the patient. Okay. Now, if you have a patient where the patient is adequate spontaneous ventilation and cooperative, so the patient is So the patient is cooperative, patient is breathing, okay, there is adequate respiratory efforts. You can keep the mask, that is non-rebreather mask, and the patient is breathing for 3 to 4 minutes. Patient is, having this pre-oxygenation 3 to 5 minutes from this non-rebreather mask. Now, there is one concept of, as I said earlier, that flush flow rate oxygen. Now, what is flush flow rate oxygen? You usually keep this, up to 15 liters, but it is always good that if you keep on increasing or turning this knob of oxygen till it gets it's not turning out. That is what is the concept of flush flow rate oxygen. Now it has been seen, if you keep it at the 15 liters per minute, then the percentage of oxygen maximum will be 65. Now, if you are keeping on increasing this knob of oxygen, the amount of oxygen or percentage of oxygen will be increased up to 90%. That is quite enough. So, advise you go for flush flow rate oxygen. Now, the other thing is about if the patient is not breathing adequately. Okay, so the patient is not breathing adequately, you have to pre-oxygenate. How you can pre-oxygenate? So you can do the bag mask well ventilation. Okay, that has to be synchronized with the patient. What does the synchronization mean? That you have to give the breath positive pressure ventilation at the time when patient is inhaling inside. Otherwise, there will be desynchrony, patient will not tolerate, and it will be more problem to the patient. So the synchronized breaths very important if the patient is inadequately breathing, and this will play a vital role in pre-oxygenation. Now, the third case, what we can have a patient who is breathing spontaneously but non-cooperative. Patient is not cooperative. So what you can do in this situation, now there comes the role of delayed sequence intubation. Now, what is delayed sequence intubation?
It involves administration of dissociative dose of ketamine 1 mg per kg IV or 3 to 5 mg per kg intramuscular, intended to sedate the patient sufficiently to allow effective pre-oxygenation without depressing respiratory drive. So ketamine has this property that it doesn't lead to the respiratory depression. Now, once ketamine takes effect, pre-oxygenation is performed.
So that is the concept of delayed sequence intubation. Now, moving to the other, if the patient is having high right to left intrapulmonary shunting, for example, if a patient is ARDS patient, if the patient is COPD, asthmatic patients, interstitial lung disease, now in that situation, how we can achieve the pre-oxygenation? The advice is that if the patient is having ARDS, saturation is on the lower side, you have done the pre-oxygenation, but it has not increased more than 93%. It's always good that you do the, you use the non-invasive ventilation with PEEP, so that there will be recruitment and pre-oxygenation to some extent will be improved. If you don't have non-invasive ventilator available, it is better to go for bag mask with PEEP, so that there will be recruitment and pre-oxygenation will be done. And if the patient is not cooperative, you can do the pre-oxygenation by keeping the high flow nasal cannula, and you can pre-oxygenate the patient. Now, in any situation, the idea is in any situation, you have to pre-oxygenate. There is no excuse that you will not do pre-oxygenation and you will proceed for RSI. Now, you can optimize the pre-oxygenation. There are methods to optimize the pre-oxygenation by positioning also. You can keep the patient head up position 30 degree if it is not contraindicated. You can keep the patient in, reverse Trendelenburg position where the patient's whole body is on the high side, upside. So you can do the pre-oxygenation. The idea is that the functional residual capacity, while you are keeping it up, functional residual capacity increases. And With this, there is increase in the oxygen reserve. With this, there is increase in the oxygen, overall, the time that will be for the safe apnea time. Now, moving to the other part, the importance of cricoid pressure. Now, whether we have to do this cricoid pressure or not, now there has been several studies that have proven that this cricoid pressure is not going to prevent the patient from aspiration. So routine cricoid pressure is not advised. So don't do it if you have not any reason. If you just want to prevent the aspiration, you will put this cricoid, you will do this cricoid pressure. So routinely don't do this cricoid pressure. Where you have to do this cricoid pressure, as I said, if you have a patient where you have to do this bag mask ventilation during the time of apnea, the patient is not tolerating the apnea, patient has gone into desaturation, now you have to do the gentle ventilation. At that time, you can use this cricoid pressure in order to decrease the gastric insufflation and decrease the problem, that is the aspiration risk. So gentle ventilation for patients, as I said, you can do this gentle ventilation for patients who cannot tolerate apnea. But yes, you have to do the bag mask, you have to use the PEEP, or you have to make sure that you are using the cricoid pressure at that time. Now, the other is the concept of what is known as continuous passive oxygenation, apneic oxygenation, continuous passive oxygenation during apnea. Now, the concept is simple. When the patient is in apnea where you have to wait for intubating condition, there is diffusion that is continuously happening at the alveolar level. So keep this nasal cannula there. You are waiting for patient for that intubating condition to happen. Now keep this cannula there with 15 liter there, okay, and there will be continuously oxygenation or diffusion that is happening at the alveolar level, and this will increase the safe apnea time, and this will decrease the event of hypoxia or intolerance to that period of apnea, especially in critically ill patients. So if you have a patient who is not, you feel that patient is having, high right to left shunt, ARDS patients, critically ill patients, you are rushing for now this pre-oxygenation. You have done pre-oxygenation with non-invasive. Just keep this nasal cannula there in order to this safe in order to increase the safe apnea time, and tolerance for apnea will happen. Now, moving to the another important step of RSI is physiological pre-optimization. Now, this is one of the important things that we have to think before giving sedatives and muscle relaxation. Now, if the patient is hypotensive, make sure that you are trying to optimize blood pressure more than 90 or keeping the mean arterial pressure more than 65. If the patient is having less than 90, you are giving sedatives and muscle relaxant, there is high possibility of peri-intubation cardiovascular event that can happen. And that is what is I was discussing, that is what is the physiological difficult airway. So if the patient, you find out the reason for the hypotension, and accordingly give fluids. If the patient is hypovolemic, give fluids. If the patient is septic, start inotropic agents as soon as possible. And if not, this blood pressure is not getting above 90, before giving push dose pressure, don't give sedatives and muscle relaxation. Now, what is this push dose pressure? Two drugs that are recommended, one is the phenylephrine and the other is the adrenaline. So phenylephrine at the dose of 50 to 200 microgram, you can give it IV push, and after that you can give sedations and muscle relaxant. For adrenaline, you can give 5 to 20 microgram IV push of adrenaline, and after that you can give the muscle relaxant and sedatives accordingly. Now, if the patient is hypoxic, already discussed, you have to do the pre-oxygenation at its optimal way. Like you can use non-invasive, you can use high flow nasal cannula. Now the concept is you have to make sure that the oxygen saturation is getting more than 93. Patient can tolerate the apnea period, and for that you can use these non-invasive and high flow nasal cannula. But yes, you have to make sure you are doing your best to optimize before giving sedatives and the muscle relaxants, so that this peri-intubation cardiovascular event can be minimized. Now moving to the other part, that is essential part of RSI, is paralysis with induction. Now, what are the options for sedatives? We have induction agents like propofol, we have ketamine, we have etomidate, we have midazolam, but rarely we can we use midazolam as an induction agent. So propofol, we have to be careful that if a patient is hypotensive, so just avoid propofol, otherwise it can lead to more exaggerated response. If you have a patient who is hemodynamically unstable, it is better to go for etomidate, and because the hemodynamic profile, stability is better with etomidate. If you have a patient where you don't have availability of etomidate, and you have to choose between propofol and ketamine, you can go for ketamine because it has a sympathetic response, so it can increase rather than decreasing the blood pressure, it can increase the blood pressure and heart rate also. But yes, there are conditions where you have to be careful. Now other is the neuromuscular blocking agent. So we have two neuromuscular blocking agents that we often use. One is succinylcholine and other is rocuronium. Succinylcholine, if the patient is not having any contraindications like hyperkalemia, rhabdomyolysis, crush syndrome, or if the patient is not having burns more than 72 hours, you can use the succinylcholine. Usually we try to avoid using succinylcholine in critically ill patients. So we try to avoid because the possibility of hyperkalemia or exaggerated response could be there. So we try to avoid in critically ill patients. But yes, in emergency situations where you have to secure airway, you can use succinylcholine. And the best thing about succinylcholine is that induction is very fast. Patient goes into muscle paralysis within 40 to 45 seconds and comes back within 5 to 10 minutes of time duration. Now you have the other option like rocuronium. If a patient is critically ill and you need that muscle relaxation, you can use rocuronium as a part of RSI. But the only thing is that the duration of onset is a little bit far, greater or longer than the succinylcholine. Maybe it will take 60 seconds or more than 60 seconds for complete muscle relaxation to happen. So you have to be careful in a situation where you have a patient who cannot tolerate the apnea period. In that situation, you don't want to give succinylcholine, you proceeded for rocuronium. Maybe you might have to give the gentle ventilation, as I was already discussing. So rocuronium and succinylcholine, these are the two options what we generally use for the rapid sequence intubation. And the rocuronium, there is one thing about rocuronium. There is this reversal agent, that is what is known as the Sugamadex. Okay, now the myth about I can say the Sugamadex is that if you give the rocuronium, the reversal will be very fast and you can avoid the can't intubate and can't ventilate situation. But let me tell you, the sedation or the respiratory backup will not be as soon as you are giving this muscle reversal. Okay, so you have to be pretty sure about the airway in this situation also. Don't think that Sugamadex is something miracle will happen and you will have a rescue from can't ventilate and can't intubate situation. And same is for ketamine. Don't think that if you have a patient with hypotension and you are giving ketamine, now the BP will increase. So there is possibility that blood pressure can decrease also. Patient can have more hypotensive response with ketamine also, where there is like decreased sympathetic response, especially in septic patients. So this is about paralysis with induction. Now moving to the other part. Now moving to the other P, that is the positioning of the patient. It's important to position the patient while doing RSI. You keep the position 30-degree head up, or if it is contraindicated, you can go for reverse Trendelenburg position. Now the other is placement with proof. Now what does it mean, placement with proof is that you have to be sure whether this endotracheal tube, when you have intubated the patient, it has to be in place, it has to go inside the trachea. Now the best gold standard monitor to say that it is in trachea, it is the end-tidal CO2 monitor. So you have the monitor of end-tidal CO2 that is available in ER. Most of the times you have the small portable version, that is the colorimeter of end-tidal CO2, that changes the color from purple to yellow when the CO2 percentage is more than 4%. So you can use these gold standards to make sure that the tube is in place. The other are like, you have to see the bilateral air entry, and you have to do, after then you have to do the x-ray, you have to see the position of the endotracheal tube, whether it is not going more inside, or there is no endobronchial intubation. Now, the other P, that is what is known as the post-intubation management. Now, there has been one article that has, detected that most of the times when the patient has got rocuronium as a part of RSI, their percentage of awareness after RSI was very high. They were aware because they don't receive the sedation as soon as possible when intubation is done. So what is advised whenever you are using, whenever you have done the RSI, it is always good you start the sedation immediately. If you are thinking that the patient is having hypotension, if you start the sedation, it will be more exaggerated response. But start with low dose, or start with some inotropic agent or vasopressors, so that you can titrate your sedation. Awareness is very bad if the patient is aware. If the patient is having muscle relaxation, patient is not getting sedatives, and this will be not a good thing for the patient. And you have to make sure that you are giving sedatives as soon as possible when you have intubated the patient. Thanks for watching this video. If you have any queries regarding this video, regarding this topic, please let me know. Write down in comment section. I will be happy to answer all of your queries.